Hi, welcome to our February seminar as part of the Prevention Research Center for Healthy Neighborhoods seminar series. Before we get started, just a few logistics and some housekeeping for today's seminar. We recognize that in this format, you can't see who all is on the call. So if you could please use the chat feature to write down your name and your organization to let others know who is here and joining the presentation today. For any questions, we ask that you please use the Q&A feature. Also, there's a raise your hand feature. So when we do go into the question and answer portion of the webinar today, you can use that feature to ask that your microphone be unmuted. We are excited today to have Dr. Alana Rojewski at our seminar today. Dr. Rojewski is an assistant professor of public health sciences and associate director of the tobacco treatment program at the Medical University of South Carolina. And she'll be presenting today on barriers and potential solutions to increasing the availability of successful evidence-based tobacco treatment programs in healthcare systems. Dr. Rojewski's program of research is focused on the development of tobacco treatment interventions for people with comorbid conditions and the implementation of tobacco treatment interventions in the healthcare setting. Dr. Rojewski was awarded an NCI CO7 in 2017 to investigate a game-frame text messaging intervention that is tailored to lung cancer screening patients. She also serves as a co-investigator on several NCI-funded R01s. Dr. Rojewski received her degree from the University of Florida and completed a NIDA postdoctoral fellowship at Yale School of Medicine. I'd like to welcome today Dr. Rojewski.
Hi, thank you so much for that kind introduction. Let me just go ahead and share my screen. All right, thank you. Thank you again for that introduction, and thank you to Dr. Trappel for having me here today. I actually grew up in Ohio and went to college there, so I'm particularly thrilled to be here with you today, although I wish it could be in person. And so today I'll be, like Sarah said, talking about tobacco treatment interventions and overcoming how we can overcoming barriers for people with comorbid conditions in the healthcare setting. And so I was learning a little bit about what you do at the Prevention Research Center for Healthy Neighborhoods. And I recognize that some of you may be coming to this talk today from various healthcare settings. So I'm going to be using the term healthcare setting today pretty broadly. And a lot of my examples are going to be in hospitals specifically, but really I think that this applies across the spectrum of the healthcare setting. So those of you who are coming from community clinics or who work in that space, I think a lot of this will be relevant to you as well. And with tobacco treatment being one of the more impactful prevention approaches we can take for health, I hope that you all can take something away from this today. So the overall goal of my program of research is to help people quit smoking. And so I see my work, again, kind of on a continuum where I have done some work in tobacco treatment intervention development for people who have comorbid conditions or who, in the case of my KO7, who are attending lung screening. We develop those treatment approaches. We test them through pilot studies. We spend some time refining the intervention, seeing how we can improve upon it. We then engage in large-scale clinical trial testing. And recently, I've become pretty interested in how we then take our findings and implement those approaches back into our healthcare setting. So once we know that something works, how can we plan to get it into the healthcare setting? Is it something that's going to work? So that bridging that gap between effectiveness and implementation is something I've recently been pursuing. We also have a tobacco treatment program here at MUSC, which I'll tell you a little bit about later. And so it's both a research interest of mine as well as a clinical interest, because I also am the associate director of our program. So looking to get as much effective tobacco treatment to as many people as possible. So for those of you who are perhaps less familiar with tobacco treatment approaches, there's been a wealth of research over the years, numerous clinical practice guidelines demonstrating that a combination of behavioral and pharmacological treatments for smoking is really the most effective. These things are effective on their own, but in combination, this is the best sort of treatment package that we have. Pharmacological options are things like nicotine replacement patches, gum, and lozenge. I don't have a picture of lozenges on here, but those are like standard size lozenges as well as mini lozenges. We also have prescription options like Chantix and bupropion. And then, of course, when it comes to counseling, there are numerous approaches to this. So this could be one-on-one, like outpatient counseling. It can be inpatient counseling at the bedside where somebody is perhaps inpatient in a hospital. It can come from the State Smokers Quit line through text messages. There's various ways to deliver counseling and also different types of counseling approaches. So both the content and the mode of delivery can vary. And so one thing that I find really interesting is sort of how we package these interventions in a way to be most effective for people who have comorbid conditions. So when we have people in our clinic who have perhaps cancer, heart disease, any number of comorbidities, what is going to work best for them? And I'm not sure that we really have the answer to that just yet, but trying to find the most effective approach for them is important because they are faced with a medical diagnosis or a psychiatric diagnosis that can make quitting challenging for them, and they are still smoking despite that diagnosis. And so really finding the most effective intervention for them possible is important. And so a few years ago, I participated in this work group with some colleagues from the SRNT treatment network. And so we were really interested in exploring this exact issue. So we wanted to know, in terms of, we picked 5 representative comorbid conditions. You can see them listed here. But among these patients, we were really interested in evaluating the prevalence of smoking and the harm of smoking in each of these disease groups, the effect of their disease on the ability to quit smoking, the association between their use and their comorbid treatment outcomes, and then the evidence regarding potential approaches to improve cessation for those particular groups. Now, this is a really big review that we engaged in. And so I'm going to be kind of giving these very like broad strokes of what we found, what our conclusions were, and some of the data from each of these disease groups. But if you have interest in going back to the original publication to look at specific studies or to get specific citations, I encourage you to do that. You can refer back to the original publication. Otherwise, I would have a list of like 150 references, which is outside of the scope of this talk. So in doing this, and I'll get into the specific disease groups here in a minute, but I wanted to kind of just present to you the common themes that we came up with in terms of addressing tobacco use for people who have these comorbid conditions. So sort of the thing that jumped out at us first in our review is that tobacco assessment and cessation support is really not well incorporated into clinical care or research for any of these disease groups. So this may seem kind of surprising, perhaps, that tobacco assessment is not something that's well incorporated, but not all healthcare systems have electronic health records. And so, even if they do have an electronic health record, they may not be assessing for tobacco use at every visit. And so we don't know how to treat our patients if we don't know that they're actually smoking. So assessment of tobacco use is really like the first thing that has to happen. But cessation support is also not well incorporated. Not many healthcare systems have dedicated tobacco treatment support. And so this is something that we found to be pretty lacking when we were reviewing the literature. We also found that people who have comorbid conditions appear to have similar or improved motivation to quit relative to their counterparts who don't have these comorbid conditions. So it's not so much that they're not motivated to quit smoking in the context of their diagnosis. It's just that they're not having success with quitting. And so we also found that the teachable moment may be something that's useful in improving their motivation to quit. We found this in a couple of different disease groups. We also found that multiple comorbid conditions may occur within a single patient. So sometimes we tend to think in silos, right? Like we think about people who have HIV or are cancer patients, but the reality is that people are probably coming to the table with numerous comorbidities, and that includes perhaps like a psychiatric diagnosis combined with cardiovascular disease and diabetes and any number of other things. And they're also smoking. So what we're dealing with are very complex patients. And we may need to take all of this into consideration when developing individualized care for them. Also of note, smoking cessation medications may interact with medications used to treat their conditions. So there aren't many contraindications for nicotine replacement therapy and Chantix, but there are a few, and they are worth noting. Like just for example, people who have severe renal impairment um, are kind of questionable on whether they can use varenicline. So just things like that, where we need to just be taking into consideration that they have complex medical conditions that really need somebody to evaluate the full spectrum of what they're currently taking for their comorbid disease. Evidence-based approaches to cessation can be used across comorbid conditions. So like we have an arsenal of evidence-based tobacco treatment interventions that can be used across these conditions. They are generally effective. The question still remains, and I'll get to this in a little bit, what can be done to make this even better, to improve upon this for specific groups? But in general, the evidence-based approaches that we have are effective. And all people who use tobacco, regardless of their comorbidities, should receive evidence-based support. So to get into each of these disease groups a little bit more in depth, I'm going to kind of go over the prevalence and harm of each and kind of where we are with how we address tobacco treatment for them. So those individuals who have psychiatric comorbidities are more likely to smoke than people who don't have those diagnoses, and vice versa. So those who don't have those diagnoses are less likely to smoke. For some who have those diagnoses, especially things like schizophrenia and substance abuse, smoking rates can be as much as 4 times greater than in the general population. So this is a group of diagnoses that are kind of across the board. You might have like anxiety and stress on one end, and more severe diagnoses of schizophrenia on the other end, but smoking rates are higher than in the general population. There is mixed evidence in the literature on the motivation to quit among these groups. So there are at least 4 issues that we identify that can impair cessation motivation. So, and a lot of these are misperceptions. So, you know, some may feel that that there's like a fear of worsening mental health or even drug relapse after quitting. We find that this actually isn't the case in the literature. Like when you actually look at it, you actually see that people who have psychiatric diagnoses and quit have an improvement in their psychiatric symptoms, but there is that fear that they may have worsening depression or worsening stress when they engage in a quit attempt. That doesn't really seem to be the case, but it certainly can impact their motivation to quit. Often people who are being seen for psychiatric treatment are in treatment environments that support continued smoking. So this might seem kind of shocking, but if you think about like smoke breaks in treatment groups, so somebody who's attending perhaps an outpatient treatment for their psychiatric diagnoses or their substance use, they may engage in smoke breaks. They may have counselors who themselves are current smokers. And so there is just not that level of support in their treatment environment. There's also a lack of understanding on the health risks of smoking at the level of the individual and where they can access treatment resources. And psychiatric symptoms just in general may impede motivation and success in quitting. So there could be a lack of coping skills, poor distress tolerance, emotional dysregulation, and all of those things can really hinder success. So we know that some of these diagnoses, individuals who have these diagnoses can respond to evidence-based medications more than others. So we know that, for example, Chantix is a little bit more effective for people who have depression and schizophrenia. Bupropion is really good for people who have past depression. It actually is a depression medication, but it just also happens to help people quit smoking. There are those who are less responsive. So people who have anxiety and substance use disorders can respond a little bit, their response is a little bit less to these types of pharmacological approaches. But they may have more success in other types of behavioral approaches to cessation. With respect to cancer comorbidities, so this is probably like not news to anybody. We know that smoking causes cancer. The most recent Surgeon General's report now has a list of 17 cancers that are directly caused by smoking. There were several that were added to the most recent report. Smoking increases all-cause mortality by a median of 51% and cancer-specific mortality by a median of 61%. And smoking is also associated with an increased risk for second primary cancers, a risk of recurrence of the primary cancer, poorer response to treatment, and increased treatment-related toxicity. And that's across all treatment groups. So in terms of their poor response to their cancer treatment. So it can make their chemo less effective. It can make their surgical outcomes worse. It can make their radiation less effective. And then you can also get that increased treatment-related toxicity. So it's incredibly important for our cancer patients to quit. Our message is that it's never too late. Just because you have cancer does not mean that you get the free pass. It's still important for people to quit smoking. And so those who have cancer comorbidities, we found in this review of the literature that the teachable moment can be pretty relevant to our cancer patients. They're handed this diagnosis. I think that a lot of people spend their life thinking like, well, I don't have cancer, so I can just keep smoking. It's like a free pass. But once they are faced with that diagnosis, there may be this teachable moment that happens where it dawns on them like, well, now I finally do have this health problem and I need to be proactive about fixing it. And so you may see some people who quit at the time of their diagnosis and can quit like cold turkey. But we still see numerous cancer patients, especially in our clinic, who are still smoking through their cancer treatment. And so, they can be facing significant barriers, stress of their diagnosis. They may feel hopeless. And this can lead to lower readiness or motivation to quit and lower self-confidence in being able to quit alone. And so having that level of support, we'll talk about sort of having that programmatic support in place in a little bit. But supporting them through a quit attempt is incredibly important. So in the literature, there have been several surveys of oncologists to look at how tobacco treatment is implemented in oncology care. And it's pretty consistent. These numbers can kind of vary, but for the most part, most oncologists will ask their patients about tobacco use. About 80% of them, so slightly less, will advise them to quit smoking, but less than half of them are actually regularly providing tobacco cessation support. And there are several reasons for this that we'll get into a little later. But this just kind of goes to show you this, it's disparity in terms of what people are saying and what's actually happening in terms of access to these services. But like I said, because they're still smoking through their treatment and that teachable moment doesn't really work for everybody, that it can be the case that intensive and evidence-based interventions are required. And individualized interventions may be needed because there aren't, like I said, there are not many contraindications for tobacco cessation pharmacotherapies, but there are some considerations. For example, patients who are taking tamoxifen, which is something that's typically prescribed for the treatment of breast cancer, can be contraindicated with bupropion, for example, if they're trying to quit smoking. So these are just things to take into consideration, and an individualized approach for cancer patients may be warranted. All right, when it comes to cardiovascular comorbidities, we know that smoking is a risk factor for cardiovascular disease. This includes heart attack, stroke, atherosclerosis. Approximately 150,000 people aged 35 and older in the US die each year from smoking-related CVD. So that's not even like something that we're talking about where, like older smokers are bearing sort of the brunt of the disease process. This is people 35 and over. So even people who are relatively young in the middle of life are having CVD from smoking and are dying from it. So again, this is a group that the teachable moment may be something that's pretty important. Cardiac events and surgery for CVD can be a teachable moment, but the literature suggests that it may depend on the type of intervention that's required to treat the disease. So people who are having, for example, like an open revascularization, where like the recovery is grueling, it's a much more intense procedure, they may be more likely to quit just because their hospital stay is a little bit longer, they feel worse than somebody who's having a percutaneous approach to their treatment. So it may not be the diagnosis of their cardiovascular disease per se, but sort of what they're enduring to treat it. And patients who present for CVD, treatment may also need to be evaluated for psychiatric comorbidities. You know, we know that stress and anxiety and depression are associated with CVD just in and of themselves. And smoking is also independently related to those psychiatric comorbidities. So we're ending up with this like trifecta problem of people who are stressed and anxious and depressed and have CVD and are smoking. And so this is a group that we may need to have a little bit more intensive and individualized approaches for. I will note, so since we published this review, there was this beautiful paper that was done by a work group from the American College of Cardiology, where they were coming up with a treatment decision pathway for use in cardiovascular clinics. Although I will say that this is so comprehensive, I think this could be used in any clinic. But it just goes to show you that that there is that support sort of at like the broader level for how these different interventions are done and sort of treatment decision pathways for how they can be implemented in care. And so, you know, at the end of the day, this work group, this is just to show you the schematic of what they came up with. But at the end of the day, they believe that everybody should be discharged from a CVD event with medication to help them quit smoking. So that includes Chantix, that includes nicotine replacement therapy, anything we can do to discharge them with meds and to facilitate them quitting is going to improve their clinical outcomes for their cardiovascular disease. All right, pulmonary comorbidities. Cigarette smoking is the dominant cause of COPD in both men and women in the US. Smoking can cause acute exacerbation of asthma in adults, increased risk of TB infection, and increased mortality due to TB infection. We also see that smoking cessation, so being able to quit smoking, can stop that decline in pulmonary function. So there is some pulmonary function that can be recovered by quitting smoking. And I will also say this is a group that we see that pharmacological and behavioral interventions that we already have can work for this population. There have been some guidelines recently published, again, since we did this review, by the American Thoracic Society with decision pathways for how to treat patients who are seen in pulmonary settings. But it really is going to come down to how it's implemented. People who have COPD may be equally as motivated to quit, but just may require more intensive pharmacotherapy regimens to achieve abstinence. And we can try different strategies, much like the teachable moment. With this group, we can try the approach of lung age. So this concept of lung age has shown promise in motivating people with lung disease to quit. And lung age is basically, it's based on the FEV1 that I mentioned before, but the lung age in a patient who smokes will be much higher than his or her chronological age. So a 35-year-old smoker may have a lung age of 50. And so that may be motivating in telling people that they can recover some of that function by quitting. And like I said, again, this is something where both behavioral and pharmacological treatments that we already have can be effective for these patients, but really it's a matter of getting it into their hands. Okay, and our final comorbidity group that we were evaluating is those who are living with HIV and AIDS. So smoking prevalence among people with HIV is 2 to 4 times higher than the general population. People with HIV smoke a greater number of cigarettes per day. They're more nicotine dependent and are less successful at quitting. and they are more likely to suffer the adverse health consequences of smoking. So now that we have pretty successful antiretroviral therapy regimens, people who have HIV are living much longer than they ever were. And because they are then smoking for many more years of their life, they are more likely to die from lung cancer than they are from their HIV-related symptoms. And so they have cancer, they have CVD, they have respiratory disease. And so there's been quite a bit of the research on how to best treat people with HIV/AIDS for smoking is it's still relatively in its infancy. There has been some research that's been done in terms of tailoring interventions to help them quit, but there has been more that's been done recently, and I'll talk a little bit about that. So we know that smoking cessation obviously is helpful in reducing their CVD risk and lung cancer risk, but also bacterial pneumonia and their HIV symptom burden. Most people who have HIV are motivated to quit and have made a quit attempt during their lifetime. But they may face barriers. So, and those barriers can be at any level. So they may face systemic barriers in terms of access to treatment, social barriers, much the same way that people with psychiatric comorbidities have social circles that smoke. It's the same with people who have HIV, and they may have additional comorbidities that need to be addressed to improve their motivation to quit and success. We also, there's been some emerging research from we have some colleagues at Penn who have been looking at the effectiveness of nicotine replacement therapy for people who have HIV. And they found that people who have HIV actually metabolize nicotine much faster than their non-HIV counterparts. And so because of that, standard dosing of nicotine replacement is less effective for these people. So it may be that they just need larger doses of NRT to accomplish the same rates of success as their non-HIV counterparts. And there actually recently was an RFA that was put out looking to fund projects evaluating tobacco treatment interventions for people living with HIV. So I'm hopeful that in the coming years, we'll know a little bit more about ways that we can better address smoking in this group. So I want to, we kind of came up at the end of this paper with future research considerations that I'd like to pose to all of you, because as people who engage in research for prevention, I think that this is really important. And so some of the considerations that we floated include identifying the optimal timing, method, intensity, and the type of provider to deliver these cessation treatments in specific clinical environments, calculating the cost benefits of smoking cessation treatments in different comorbid populations, how smoking cessation treatment can be implemented in the context of the multiple comorbidity issue that I've brought up a few times, identifying how smoking and cessation affect comorbid disease outcomes. We know a little bit about that, like with respect to cancer, I mentioned about like treatment toxicity and things like that, but among the other groups, we don't know too much about how it affects their medical outcomes. And also understanding the relationship between smoking and other comorbidities not reviewed here. So there are certainly others, diabetes, surgical complications, things of that nature. So this is my call to arms. I encourage all of you to get out and do this type of research and help us answer some of these questions. So before I go on, I have the talk kind of broken up into different segments. I'll pause here and see if we have any questions.
And as a reminder, you can type questions into the Q&A feature or use the raise hand feature to request that your microphone be unmuted. So we do have one question in the Q&A. Have you looked into diabetes? Should smoking diabetic patients who have a hospital stay go home with a cessation treatment?
So yes, so you were like right ahead of me on that question. We in this review did not look into a diabetes cohort or the research that exists for smoking cessation with people who have diabetes. But I will say that my knowledge of that is that absolutely quitting smoking would be beneficial to them, and absolutely they should be sent home with cessation plans. So whether that is, I'm not sure what you have access to wherever you are that you're asking this specific question, but If you have a way to get them into dedicated tobacco treatment services, I would recommend that. And also every state in this country has access to the state tobacco quit line. So you can call 1-800-QUIT-NOW from anywhere and be connected to people who can offer pharmacotherapy. It's not all quit lines, but most quit lines will offer free nicotine replacement therapy, or you can connect them to providers, but certainly like whoever is discharging them from the hospital, the person who was in charge of their care while they were inpatient should be discharging them with cessation medications if they're a current smoker. Yes. And I'll talk a little bit more about kind of how that looks programmatically in a little bit. Thank you for that question. So we were on a good roll with this work group I was part of. And so we actually ended up publishing a second paper, because once we kind of got through all of the individual level considerations with comorbid conditions, we started thinking, like, just because these individuals have perhaps sort of roadblocks in their way because of their disease process, what happens when they're actually in a healthcare system? Do they have systemic barriers that they're facing that are limiting their access to tobacco treatment? So we sort of took an approach. This was also a review, although not like a formal systematic review. We were kind of taking our own experiences and going out into the literature to see what was out there in terms of the barriers that we had all identified within our own clinical experiences. Again, please refer back to this publication for any of the references I'll mention. This was, again, like a huge review and undertaking, lots of references. The way I would like to approach this, so I'm going to give, and we did this in the paper as well, we had case vignettes that we used to highlight some of these systemic barriers. So what I'd like to do, I'm going to present you all with 2 case vignettes, and then I would like for you to, I'll pose some questions. I'd love for this to be interactive. You can use the Q&A feature, you can use the chat feature, or raise your hand. I think Sarah told me you can do that too. So I would like to hear your feedback kind of on how you view these case vignettes I'm gonna give you. So our first case is Mrs. Smith. She's a 57-year-old female who is newly diagnosed with lung cancer. She's been smoking a pack a day for the last 33 years and has a history of clinical depression. She's been advised to quit smoking by her surgeon, but she's been getting conflicting messages about quitting from other healthcare providers. So she has a primary care provider, her psychologist, who are very worried about her prior depression and don't want her to have a relapse because they know she's already really stressed and upset about her cancer diagnosis. The cancer center where the surgeon is practicing does not offer dedicated tobacco treatment services. And so the surgeon, who still is adamant that he wants her to quit before surgery, recommends that Mrs. Smith pick up some type of nicotine replacement from her local drugstore. It's available over the counter. But he doesn't take the time to discuss how to use the nicotine replacement products, develop a quit plan, or talk about her willingness to quit. And so because of that, Mrs. Smith is pretty overwhelmed by the options that are out there, the stress and anxiety of the new cancer diagnosis, and it kind of goes nowhere. She doesn't know where to start. She doesn't know what to do. So tell me your feelings about this. What are some of the barriers that you're seeing just kind of off the bat with this particular case vignette? Let me pull up the chat box so I can actually see this. Okay. Conflicting information from different providers, definitely. Conflicting messages, a huge barrier. Yes, a long history of smoking. And how are we going to do that? No support team, right? So there is no team at the hospital where the surgeon can send, no resources in the office. Right, so no resources in the office. I'll expand upon that a little bit, and we'll kind of go into this in a little bit, but no resources in the office is also at the level of the surgeon, right? So this surgeon, whose job is to operate, supports tobacco treatment, but doesn't actually know what to do. They're not trained in tobacco treatment intervention delivery. All he knows is that there's stuff available over the counter, which is great, and sometimes more than most surgeons would even offer, but it falls a little bit short. And so we have a patient who needs to quit and is getting conflicting messages and doesn't have good support and doesn't know what to do and is incredibly overwhelmed. And so you can see that this, somebody said, I think it would be a good idea for all of her doctors to talk about her care. Right. So there's not a lot of crosstalk among the providers to even discussing what the message is to her and sort of the comprehensiveness of her care for her depression and her lung cancer, her upcoming surgery, what that looks like once she's discharged. There's just a lot of systemic barrier here. And we'll talk, I'll kind of go over what all of our identified barriers were. I'd like to present you with the next case though. Oh wait, gotta close the chat box. Okay. Okay, so Miss Johnson. So Miss Johnson is a 45-year-old woman who is in a methadone maintenance treatment program where she's been for the last 10 years. She has a history of cocaine and heroin use. She smoked 1 pack of cigarettes per day starting at age 14, but she about 6 months ago cut down to about 10 cigarettes a day. She had been abstinent from illicit drugs for 3 years, but 1 month ago she had a lapse. And at the time of her lapse, she started attending an intensive outpatient program for substance use disorder to kind of get her back to her period of abstinence. At this intensive outpatient program, she goes out on smoke breaks with her peers, and the counselor at this outpatient center also smokes. So tobacco treatment is not prioritized as part of this treatment for her substance use disorder. And now that she's back in this treatment with fellow smokers, she's actually increased her smoking from 10 cigarettes a day to 15 and is generally ambivalent about quitting smoking. So we have a network of people who smoke and a person who's ambivalent about their care. So what do we see here kind of in the big picture about where she might be encountering some systemic barriers? So somebody said, Melissa, too many things to quit at once is a common comment I hear from patients. Yes. Yes, they don't want to give up everything at one time. So they choose to focus on one drug at a time. And it's often the case that tobacco use is at the end of that because it's not illicit, despite the fact that there are significant health problems associated with it. Counselor smokes with their patients. You are shocked. There's an exclamation point in that question. It is not very focused treatment. And you would be, I mean, like horrified to know that this is actually really common. So a lot of providers who are in these kinds of inpatient, the intensive outpatient programs. So if you think about a place that's like for alcohol use disorder, may have a, it's like people who are 12-step program based. A lot of those people are also in recovery. The counselors themselves are also in recovery. And so they also have smoked for most of their life and have also not prioritized quitting. And so, yes, they end up smoking with their patients and having organized group smoke breaks. Somebody said the patient's environment does not support quitting, including the counselor. Yes, the counselor and peers are not educated about the severity of tobacco addiction as well. Yes, 100%. Lack of education is a huge systemic barrier at the level of the providers as well as the other patients. Absolutely. Thank you all for contributing to this little interactive piece I had here. So I'll go over kind of like the general systemic barriers that we all identified, and you'll see that you all raised exactly these barriers. So we find first that there is insufficient training in the impact of tobacco use, the related disorders, and the evidence-based treatment approaches that are available. So curricular content can really vary by training program for all kinds of providers. So from nurses and med students and people who are going to school for social work, like across the board, curricular content varies. When we went and did some research about this for this paper, we found that training requirements that are common to residency programs for physicians none of them are the same with how they approach tobacco. There is no common curriculum. So, providers may not even learn about, what to do with nicotine replacement, despite the fact that they're in residency for cardiology. So, they're trained to address problems. And I'm not saying this is like the fault of providers. They are trained to address problems. They're trained to deal with cancer, to address cardiovascular disease. And these other comorbidities that come to light with smoking, I think really require a tailored and dedicated treatment approach that most providers just don't have. And so we'll kind of come up to this with how are we going to deal with this. Again, there can be misunderstanding among clinicians about the effectiveness of treatment. So some people think like, oh, it's too hard to quit, so why bother? Which is a gross mischaracterization. I think about the effectiveness of tobacco treatment. We have effective interventions, certainly. There can be lack of therapeutic support from clinical staff. So in the examples that I gave, there's lack of support from not just providers, but also from counselors, from various people. And if everybody is not on the same team about how we're approaching tobacco treatment, then I think that message becomes very diluted and kind of gets lost in translation. And so there can also be insufficient use of health information technology. So how are we even assessing tobacco use? Who's using it? How much are they smoking? How are we going to refer people to treatment? And then there can also be limited time and reimbursement. So as I mentioned with the cardiologist who is just like overwhelmed with treating the person with their CVD, they only have so much time to see them in the clinic, and they might not be reimbursed for providing tobacco treatment. And so with limited time and reimbursement and knowledge, it just, like with Mrs. Smith, they may be recommending tobacco treatment, like saying like, yes, you need to quit and I support you in that quit attempt, but it kind of stops there. So the actual implementation, there's a barrier to that implementation. So some things to consider for addressing barriers, systemic barriers in healthcare settings. So in all clinical settings, we recommend that providers, and that's from medical assistants to the physician and everybody in between, ask about tobacco use. Are you a current smoker? Are you interested in quitting? And advising the patient who is smoking to quit through use of evidence-based approaches. And then we also recommend either directly assisting the patient with quitting, so whether that's prescribing medication or referring them to a dedicated treatment program. In environments where tobacco treatment programs exist, I think that there are some improvements that can be made. So developing effective, efficient methods like through the electronic medical record for referral pathways, using an opt-out approach. So this is something that's kind of like relatively new, this phrasing opt-out of tobacco treatment. If you think about it, most tobacco treatment is offered as an opt-in. So it's phrased to the patient as, are you interested in quitting smoking? Would you be interested in going to see someone for your smoking? That's an opt-in. So we recommend taking an opt-out approach, which is that anybody who quits smoking is referred to tobacco treatment or prescribed medication to help them quit smoking. And whether they choose to use it or go to their appointment or not is on them, and they can opt out if they want to, but the message is we support you in quitting, and this is how we can help you accomplish that. And then also coming up with methods for effective referral is a big issue, how those referral pathways look. In environments where no tobacco treatment programs exist, we encourage the development of dedicated programs and implementing clinically efficient and effective mechanisms to allow individual providers to deliver treatment. So whether that's like a provider has a checklist of available medications and all they have to do is click some buttons to pen that medication for discharge, whatever that looks like, but that kind of, or referral is another one, but anywhere where we can have efficient mechanisms in place will reduce the burden of time on the part of the provider to make it easy for them to to implement tobacco treatment for their patients. In deciding on a method of providing tobacco treatment, we recommend considering the potential income generated through traditional fee-for-service approaches and the substantial long-term cost savings associated with cessation. So I'll give some numbers on this from our program here in a little bit, but this is really like a big deal for our hospital system and for our program in particular. The amount that we save on patients who have quit smoking because of a reduction in rehospitalization and better treatment outcomes for whatever their comorbid diagnosis is, we are saving the hospital money. And that is what has led to like the just very excellent support we get from our healthcare system. We also recommend involving all members of a clinical management team in providing access to treatment. And so one of you brought that up in the chat. Getting everybody on the same page is really important. And also there may be providers themselves who need access to tobacco treatment. So systems should really be supportive of also helping their employees quit smoking so that they can then help their patients quit smoking. And considering evaluating methods to increase efficiency within the clinical environment. So I'll pause to kind of like plug one method for having people who are trained professionals. So this is asked often, if we, how are you, who are these people who are tobacco treatment specialists? Like, is that a thing? Is there there's like a whole clinic that you have of people who are providing tobacco treatment? And yes, there is actually a Council for Tobacco Treatment Training Programs who there's many across the country, but they are accredited programs that train people to become certified tobacco treatment specialists. And it typically consists of about 24 contact hours where you are trained on the gamut of tobacco use and treatment. So the neurobiology of nicotine, of tobacco use disorder, different behavioral approaches to cessation, the different pharmacological options, how to do all of this, the billing, how you're intervening. So we've actually sent several of our own staff to this training program. I sat in it when I did my postdoc. I went to one of the TTS trainings just because I wanted to know what they were teaching. It's a fantastic program. And once you have somebody who's in a healthcare system, if you have one person who is trained as a tobacco treatment specialist, that person then becomes a resource for your entire system. And so if that's the point person for who you're referring your patients to, so be it. Or if they can come and impart that knowledge to the rest of the team, even better. And so I encourage you, if you're interested in developing this kind of program, or if you yourself are interested in getting trained, check out this website and find a training program closest to you. A lot of them, I also will say, are virtual these days because of COVID. So you can take it virtually, and it's perhaps even easier that way. So I'll pause here before I get into the last part of my talk to answer questions. Any questions on this last part about systemic barriers?
We do have one in the chat. How can one person treat so many patients in a hospital?
Okay, right. So I might be able to answer your question in a couple slides. We have several providers within our hospital system that I guess it depends on what the goal is. Like, is it outpatient counseling? Is it inpatient counseling? We have several people who have these various roles, but we actually currently only have one tobacco treatment provider. She's a trained TTS who sees all of our inpatients. I'll tell you a little bit about how that works, but I feel like you have to start somewhere, and having one person who can even see a percentage of your patients is better than not at all. So I think that kind of starting small and building from there. And I'm going to talk, that's actually my next little bit of this talk is about tobacco treatment program models and how you can build these types of programs. So I was part of this paper that was just published in Chest recently, just at the end of last year. It should be in press now. A group of us who are affiliated with dedicated tobacco treatment programs There were seven represented programs. We all got together and wrote this paper on tobacco treatment program models for US hospitals and outpatient centers. And so we float all of these exact issues, and I'll show you a table kind of how all of our programs are set up. But these program considerations, things like funding, like how do you start a program? Do you have, so our program was started with hospital funds. We have started to transition, some of our clinicians can bill for outpatient service. But we've started to transition to hiring providers who can bill. So we have several people who are MSWs who are cross-trained as tobacco treatment specialists who can bill for that. And we're moving from like a hospital supported program to we can be more sustainable this way because we can bill to fund these ongoing operations. And it's allowed us to expand we've actually just started expanding to our regional hospital network. But other considerations, things like counseling, who's the provider, what type of provider? We have MSWs, we have clinical psychologists, we have a clinical pharmacist, and I'll talk a little bit more about that. But what is the counseling offered? Are you referring them to the state quit line? Is it a text message based intervention? What's the what type of counseling is being offered? Is it cognitive behavioral therapy? Are you just doing some motivational interviewing? What does that look like? Pharmacotherapy. So, I recommend considering having a prescribing provider affiliated with the program so that varenicline and bupropion can be offered. But even if that's not possible, you can still make recommendations for nicotine replacement therapy that can be picked up over the counter. More considerations. So will you have referral to the state smokers quit line? For some of our patients who are who are either uninsured or are low SES, they can get free medication through our state tobacco quit line. And so if they can't afford to purchase nicotine replacement over the counter, then we direct them to the state smokers quit line where they're able to often have those medications mailed to their house. I'm not sure what you have set up for the Ohio quit line. I should have looked into that before this talk, but many of the programs do. I imagine that there is something, or maybe even like vouchers for reduced cost nicotine replacement. But anyway, how are you going to transfer them? Will it be like a warm transfer, a fax referral to the quit line? Do you have a lung cancer screening program set up within your hospital? So those of you who are coming from a hospital setting, to meet CMS criteria for reimbursement for lung cancer screening, you have to offer tobacco treatment. And so what does that look like? Do you have somebody who's actually a dedicated tobacco treatment specialist who is offering that treatment? If you developed a program for tobacco treatment, could that crosstalk to the patients with lung cancer screening? Our programs are affiliated here at our hospital, and it's allowed us to meet those CMS criteria a little bit more robustly. And then also referral pathways, like I said, with opt-out approaches, like everybody could be referred to treatment. It's just a matter of what that referral pathway looks like. Is it through the electronic health record? Is it a BPA that shows up in the electronic health record where you're then referring them to a provider? It could be a mix of both. So like I said, this is a table that I reproduced from this publication with some modifications, because we also cover all of these programs have outcome data. So you can go back to the publication to look at this, but these were the represented programs. You can see that the funding source varies across them. Some of them are hospital funded, some are funded through the NCI's C3I initiative, some are solely research grant funded. There's different kinds of counseling we offer: bedside, outpatient, quit line, text. So everybody approaches things a little bit differently, but certainly, like, if you are interested in going beyond just having like a single trained TTS to really developing more of like a programmatic approach, I encourage you to look at this paper. All of these things are considerations that kind of just depend on your specific site. If anybody has any specific questions, though, after the talk, you're welcome to email us. We can certainly make recommendations and kind of work with you on what that looks like if that was of interest. But our tobacco treatment program, it was, like I said, it was initially created, it was actually initially created using academic startup funds from faculty. So we had faculty who were tobacco treatment researchers who were just that invested in seeing a clinical program in our hospital. And so it was funded with startup funds. It's now supported by hospital funds. But like I said, we started branching out into hiring providers who can bill for service to make things a little bit more sustainable. We serve 4 inpatient hospitals and outpatient clinics in the Charleston area. The MUSC enterprise recently acquired 2 new hospital systems within South Carolina that are upstate from us. And so we've recently started to expand our tobacco treatment efforts to those hospitals as well. We have 3 kind of what I consider like branches of our program. The first is our outpatient counseling. So we have like a physical space within our hospital where we see patients. We have a clinical psychologist who is actually Dr. Ben Toll, who is the director of the clinic. He's a clinical psychologist. He's able to bill for service. He sees patients. We have a clinical pharmacist. So she's our like prescribing provider. So she has a CDTM for those of you who might be pharmacy related and know what that means. Basically, it means she just has like a referral through a provider who can sign off on her prescribing, but she can prescribe Chantix to our patients if it's warranted and wanted. We typically also have psychology interns at any point in time who do rotations through our clinic. And so they'll see patients as well. We also have inpatient services. So somebody asked how one person can see that many patients, and she does. We have 1 inpatient tobacco treatment specialist for our entire Charleston-based system. We just hired 2 new MSWs who will be servicing the newly acquired hospitals upstate. But the way that it works, we have like a system where so our person here is able to download a list. So she gets a list every morning of everybody who is in our hospital who is a current smoker. And so she's able to like see a list of like who they are, where they are in the hospital, and she goes around. She makes rounds on foot, then walks around to every room and counsels them at the bedside. It's typically very brief in these situations. This isn't like a 45-minute outpatient session, but she may just offer brief, it's a brief assessment, like, are you still a current smoker? How are you feeling? So usually we're trying to also help make sure that they're not in acute withdrawal from nicotine while they're in the hospital, because sometimes people are there for several days and their cravings might just be like out of control. So she'll recommend to the attending physician that they have at least nicotine patch while they are inpatient. Although she just told me this morning that she was able to get a provider to agree to prescribe varenicline while a patient was inpatient, which is like huge. We don't really see that very often. They're usually willing to like prescribe patches or just to kind of help, but they were willing, the patient wanted it and the provider was willing to get them on Chantix while they were in the hospital. So that was like a huge win for us this morning when she told us. But yeah, so she gets a list and she goes around and offers brief motivational interviewing. She recommends medication to the attending physician and then also puts in a note where she's able to pen medications. Well, she recommends pending medications for discharge. So she probably sees, I would say her list is probably about 30 patients every day. She doesn't quite get around to all of them. So there are some people that she ends up missing. But the way our system works, we have this third arm is our IVR. So anybody who is inpatient in our hospital is automatically enrolled in a telephonic interactive voice recognition system that will call them 3 days after they're discharged and at various time points following their discharge to see if they want to be referred either to the quit line. So they can like press a button, like press 2 if you want to be connected to the quit line. So they can be direct connected to the quit line if she wasn't able to see them, or they can be directly connected to we have a scheduler who can schedule them to be seen as an outpatient. So even people that she misses, we're still able to kind of like capture them after discharge if they are interested. And then we also have a couple of telehealth counselors who their job is really to offer some of that telehealth if the person doesn't want to come back in for outpatient treatment. We can at least, especially with our cancer patients, this has been a big initiative with them where we're calling them to see if they want to have medication or counseling, things along those lines. So we are able to demonstrate both clinical efficacy and cost effectiveness. So the data I'm going to describe briefly now is about our inpatient service. So we did a study a few years ago looking at, we had just added this tobacco treatment specialist who's seeing patients at the bedside. And so we wanted to know what it looked like for people who were receiving her service versus just the IVR follow-up. So 24% of patients who got IVR plus the bedside counseling by the tobacco treatment specialist at 1 month post-discharge had quit smoking, compared to 9% receiving the IVR alone. So we see a benefit of getting that brief motivational bedside counseling. The adjusted mean healthcare charges 12 months following discharge for patients who were treated were $7,000 lower than those who did not get our service. And so this point of like reduced cost to the healthcare system and to insurance companies is incredibly compelling for those kinds, overcoming some of those systemic barriers, or like if you can demonstrate something like this, then you're going to get that buy-in from the hospital system. And those who engaged in our services during hospitalization also had lower readmission rates at 30, 90, and 180 days post-discharge. So through systemic delivery of effective tobacco treatment interventions, we're not only able to help people quit smoking, but we're also improving their outcomes after hospitalization. So it's a pretty profound effect for being able to offer tobacco treatment to patients. So thank you. That's what I have in terms of my presentation, but I am happy to answer any remaining questions.
And as a reminder, you can use the Q&A feature. Please use that for posting questions, as well as you can use the raise hand feature if you'd like to request that your microphone be unmuted. So we have one question in the Q&A. Did you look at the difference between virtual phone programs and in-person programs?
Yes, we're actually doing that right now. So I don't have data yet, but we are evaluating especially because with COVID, we've had to go remote. We aren't seeing our patient, we are seeing our inpatients in person, but we are not seeing our outpatients in person. And so we've been kind of looking at our effective, like our quit rates during this COVID time compared to, while we've been mostly telehealth compared to before that when we were in person. But we've also looked at, we're currently looking at the quit rates associated with our telehealth counselors who call people post-discharge versus people who got the bedside counseling. So the telehealth counselors who call post-discharge is something that's been relatively new for us. So we don't have those data yet, but I hope that we do in like the next 6 months or so.
Another question in our Q&A. Has your group looked at youth programming like My Life, My Quit, and how to help teens vaping?
So our clinic, like the hospital-based program, has not. However, I have several colleagues here at MUSC who are interested in youth smoking cessation and have done research in that area, and also who are interested in youth vaping and helping to not only prevent but help people who use vapes to quit using vapes. So we're kind of interested in, that's a pretty new area of research interest for us. We have a postdoc right now who is interested in quitting vaping and strategies for that. And so it's not something that we typically don't counsel youth. So like, if I take that back, so we have a children's hospital that's affiliated with our healthcare system, and we will see people who are under the age of 18 who are current cigarette smokers if they want to quit smoking, as long as they have a parent present. But we have to be pulled to their bedside. We're not like automatically sent to Children's Hospital. We are automatically sent to Children's Hospital. So our TTS will go see children who are in the medical record identified as children who are exposed to secondhand smoke because their parents are smokers. So that's a variable, that's a trigger in our medical records, so that she is able to go and offer counseling to the parents of children who are admitted at Children's Hospital if they're exposed to secondhand smoke. So Our youth programming is just like a little bit less involved through the clinic, although, like I said, we do have that. I have colleagues who do that as a research topic.
Another question we have is, do you think the freedom from smoking 8-week classes is too long?
No, I mean, I think it just depends on the patient and what level of care that they need. So in our outpatient setting, it's like a one-on-one individualized approach. Those 8-week programs can be pretty good. I mean, in terms of like length of the program, I don't think that 8 weeks is too long. I think that it's some patients we have patients who have been coming to our program for years. So it takes them like a year to quit smoking, and they still come even like beyond that because they want the support for relapse prevention. And so I don't think an 8-week program is too long by any means, but my understanding about that program is that it's not necessarily. I know that there's some like group components to it, and sometimes they have some like modules and things of that nature. So a little bit more of a individualized approach may be more beneficial depending on the patient.
Another question is, can you speak to the presence of menthol in cigarettes and the disproportionate impact on African Americans and other communities of color?
I mean, I can speak to it in the sense that I agree that it is, I was personally of the belief that menthol should have been banned under the flavor ban that happened a few years ago. I was really disappointed to see that it wasn't. I published a paper several years ago, just doing a secondary analysis of a clinical trial that had nothing to do with menthol, but I wanted to look at people who were smoking menthol in that clinical trial, and they had worse outcomes. They were less likely to quit smoking. It was like a random clinical trial, and anyone who was smoking menthol did worse. And so, I think that the evidence is trending in that direction. It's a little bit mixed, unfortunately. We don't see like a really clear signal for the impact that menthol can have on quit rates, but like we do know that like absolutely like menthol cigarettes are targeting communities of color, and because they then have lower quit rates, we have communities of color who are still smoking at higher rates than their white counterparts, and it's really a travesty, and it's something that I do care a lot about. And so I think that creating interventions towards these marginalized communities is also really important. There's actually a really big, sorry, I was just thinking about the menthol thing. There's a really big, if you look up the Center for Black Health and Equity, I believe that's like a national affiliation, but they are currently working on pursuing policy change in different identified communities that have high rates of smoking among communities of color. And actually the Charleston area was selected as one of those target communities, where they're meeting with local groups like departments of health and other, I'm part of a Smoke-Free Low Country Coalition. It's like a grassroots coalition for community impact. And so they've been trying to get some policy implemented in these different communities to ban menthol at the local level. So if that's something that you're interested in doing in like the Cleveland area, I'm not sure if Cleveland was selected as one of those communities, but look up the Center for Black Health and Equity and look at what they're doing with menthol. It's really impressive, and I've just kind of been brought into it on like the fringe, but it's really a cool work, and I think it's really important.
We have time for 1 or 2 more questions. If there are any more, you can use the Q&A feature or the raise your hand feature. If there's no more questions, thank you so much, Dr. Rojewski. I really appreciate you speaking at our seminar series today.
Yeah, thank you so much for having me. And I mean, certainly if anybody has any follow-up questions, you're welcome to email me. My email is just my last name. It's rojewski@musc.edu. So you're welcome to contact me if you have any questions about anything I presented today, and certainly look up the articles discussed today. They have plenty of references and suggestions if you're interested in this kind of work, either clinically or research-wise.
Thank you. Our next presentation will be on March 10th, 2021 with Dr. Leslie Kofi, Assistant Professor in the Department of Health Education and Promotion. Dr. Kofi will be presenting on personal networks and cancer screening among Black immigrant women. Thank you, and we look forward to seeing you next month.